Hello, everyone, and thank you for attending today's BD FACSMatters Ask the Expert webinar on multiparameter flow cytometry in measurable residual disease. I am Annalise Barnett, Associate Marketing Manager at BD, and I'll be your moderator for this webinar. Today's speaker is Director of Medical and Scientific Affairs at BD Biosciences, Dr. Michelle McNamara. Dr. McNamara received her medical training at Meharry Medical College and completed residency training in anatomic and clinical pathology and fellowship training in hematopathology at the University of California, Davis. Her years of private clinical practice in both the reference laboratory and the hospital settings sharpened her skills in hematopathology with special emphasis in flow cytometry, having served as the director of the flow cytometry laboratory for the Southeast region of Quest Diagnostics. As an ASCP certified medical technologist, she has an in-depth knowledge of the clinical laboratory, its workflow, instruments, and unique needs. Her current research interests include the tumor microenvironment and its role in immune checkpoint inhibitor therapy and circulating tumor cells in the peripheral circulation of body fluids. We are so excited to hear from Dr. McNamara today, but before she begins, I would like to go over a few housekeeping items. If you have any questions during the webcast, please submit them through the Q&A widget of your console. Our technical application scientists will be answering them on the back end, and after the presentation, we will be having a live Q&A session. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in the background that could cause issues. Some networks cause slides to advance more slowly than others, so logging off your VPN is recommended. And if your slides are behind, pushing F5 on your keyboard will refresh the page. You can find additional answers to some common technical issues located in the Health Engagement tool at the bottom of your screen. And lastly, a recording of this broadcast will be made available after the presentation, so look out for an email with additional details on where to access it. And with that, thank you once again for joining us, and I now hand over to Dr. McNamara.
Hello, I am Dr. Michelle McNamara, and I am the Director of Medical and Scientific Affairs at BD Biosciences, and today I am going to be talking about multiparameter flow cytometry in measurable residual disease in acute myeloid leukemia. This is my background, and it has already been detailed to you by my introductory, and I'll go ahead and get started. Today I will be discussing measurable residual disease in acute myeloid leukemia. The outline includes pertinent definitions, the significance of MRD and AML, an overview of MRD testing with particular emphasis on multiparameter flow cytometry in MRD, and challenges and future perspectives in MRD AML testing. Firstly, acute myeloid leukemia definitions. I think that it is important to start with the World Health Organization classification of tumors of the hematopoietic and lymphoid system classification of acute myeloid leukemias. That is a mouthful, but I think that it's really important to start with the classifications. I'm not going to go into details of each of these, but I just want to list each type. Starting with acute myeloid leukemia with recurrent genetic abnormalities. This includes several types with balanced translocations and other mutations. Then there is acute myeloid leukemia with myelodysplasia-related changes. Then therapy-related myeloid neoplasms. And acute myeloid leukemia not otherwise specified. that has several types, which are categorized based on mostly morphology and or cell type. Myeloid sarcoma, which is not included in this discussion because it is not actually a leukemia, but rather an extramedullary proliferation of immature myeloid precursors. And myeloid proliferations associated with Down syndrome, one of which is an acute leukemia that would be applicable in this setting. Historically, for the last 60 years or so, the definition of complete remission has basically been morphologic remission consisting of a blast count of less than 5% in the bone marrow by morphologic evaluation. It also includes the absence of circulating blasts with hour rods, absence of extramedullary disease, an absolute neutrophil count greater than or equal to 1,000 per microliter, and a platelet count of greater than or equal to 100,000 per microliter. This is an illustration of a bone marrow aspirate of an overt acute myeloid leukemia at diagnosis on the left. And on the right is a bone marrow aspirate of the same patient after induction chemotherapy, showing the patient in remission. You can see on the left several large immature mononuclear cells with round to ovoid nuclei, very fine chromatin, and basophilic cytoplasm. And you can see that they have a very distinct appearance. On the right, you can see a bone marrow aspirate that has a lot of smaller, very different cells. And these are neutrophilic and erythroid cells that have a spectrum of maturation, and they don't have those large blast cells like the ones you see in the left. So this is an example on the right of complete morphologic remission with less than 5% blast. In 2016, the International Working Group updated definitions of complete response for patients with AML. The original criteria for complete remission was based completely on the morphologic assessment of less than 5% blast in the bone marrow with all of the criteria that I just described. But this criteria was not a very sensitive assessment of residual disease. So the definition of complete response was updated to include complete remission without minimal residual disease, which included negativity for a genetic marker by PCR or with negativity by multiparameter flow cytometry, with the caveat that the sensitivity of the MRD detection is varied by the marker tested and by the method used. So if the sensitivity of MRD measurements vary depending on how you measure it, was it really minimal residual disease? So the new concept of measurable residual disease became the new paradigm. So the next topic that I would like to discuss in some depth is what is the significance of AML MRD and why is this important? So this study by Oriero evaluated the prognostic impact of analyzing MRD in bone marrow by multiparameter flow cytometry in patients with AML before and after allogeneic stem cell transplant. Patients who were shown to be MRD negative by multiparameter flow cytometry before transplant had a significantly lower, the MRD negative patients had a significantly lower cumulative incidence of relapse than MRD positive patients. And MRD negative patients had significantly better disease-free survival and overall survival than MRD positive patients. So why is AML-MRD so challenging? Partly it is because of its genetic heterogeneity, and genetics is one of the strongest independent risk factors for determining the success of induction chemotherapy and the likelihood for disease recurrence and survival. So cytogenetics testing and testing for the presence of certain gene mutations are used to estimate the risk of relapse post-treatment. Almost half of adult AML patients have normal cytogenetics, and in these patients, mutations in NPM1, CEBPA, and FLT3 genes alone or in combination in younger adult patients demonstrate particular prognostic significance. This slide shows that in 2017, the European LeukemiaNet issued recommendations which risk stratify patients into 3 categories of favorable, intermediate, and adverse, based on the presence or absence of specific chromosomal abnormalities and mutations in selected genes. Based on the European LeukemiaNet genetic risk stratification, there was almost no separation between the Kaplan-Meier curves representing their intermediate and adverse risk groups for both disease-free survival and overall survival. You can see that here if you look at the red and blue lines on both of these graphs. In this study, the investigators used multivariate analysis to assess the prognostic significance that gene mutations, cytogenetic abnormalities, and clinical features had on the rate of complete remission and disease-free and overall survival of the patients. 1,377 mutations were identified with a median of 3 mutations per patient. The range was 0 to 8 mutations per patient. The most frequent mutations were in NPM1. Almost 1/2 of the patients had normal genetics and 13% had a complex karyotype. Varied analysis of NPM and the presence of a normal karyotype were associated with a higher probability of patients achieving complete remission. However, complete remission rates of NPM1 mutated patients varied from 50% to 95%, depending on whether or not other mutations coexisted with the NPM1 mutation. And that is a really large difference. So the risk categories were redefined by adding the presence or absence of additional mutations in the NPM1 mutated AML model. And the patients were reclassified into good, intermediate, and poor risk groups according to their ability to achieve complete remission. Using this model, patients could be stratified into 3 risk categories, and that demonstrated statistically significant differences in disease-free and overall survival. Here you can see that the intermediate and the poor risk groups, again in the red and blue lines, are clearly separated using this model. So the 2 studies that I just talked about have highlighted and illustrate how MRD status is independently prognostically significant in disease-free and overall survival, and that achieving clinical remission is of paramount importance in these patients. But AML is a very heterogeneous and complex disease that makes MRD assessment extremely challenging. So, next, I would like to talk about MRD testing. How can we measure? So how can we measure measurable residual disease? For decades, probably about 60 years, complete remission has been defined by conventional morphology. And it historically has been referred to as complete morphologic remission. It used to be the gold standard, but it relied on a visual determination of a blast count of less than 5% and that is a sensitivity of 1 in 20 cells. That is a very poor sensitivity, and it is manual and also has a high inter-observer variability. Cytogenetics and FISH have a sensitivity of up to 10 to the 2, which is 1 in 100 cells, and is also a relatively poor sensitivity, but these are standardized and widely accepted methodologies. Disadvantages include that these are labor-intensive and limited to patients with an aberrant karyotype, which is approximately half of AML patients, or for FISH, the patient has to have a known mutation. Multiparameter flow cytometry has a sensitivity of up to 10 to the 4th, is applicable to almost all AML patients, about 90 to 95%, and it has a relatively fast turnaround time. Disadvantages include that it is difficult to standardize and requires expert interpretation to reach its maximum sensitivity, and also because immunophenotypic shifts are common and can be difficult to identify. Reverse transcriptase quantitative polymerase chain reaction, which is a mouthful, also known as PCR, has a sensitivity of up to 10 to the 6th, which is a high sensitivity. It also has high specificity, is widely available and standardized, but it is applicable, unfortunately, to only about 40% of patients. It is labor intensive, and it has a relatively long turnaround time of several days. Next generation sequencing can have a variable intensity of up to 10 to the 6th, which is a high sensitivity, but it can also test multiple genes at once, which is great. However, it is not standardized. It has a relatively low specificity and a long turnaround time of 2 to 3 weeks. Its main disadvantage is that it can detect CHIP mutations. CHIP stands for clonal hematopoiesis of indeterminate potential. And these are mutations that can be seen in healthy non-neoplastic cells. They can even be seen in healthy people. And they can be seen in AML patients who are in remission, which could result in false positive results. So in this illustration, on the left side axis is leukemia cell burden. On the bottom axis is time, and on the right axis is the detection limit. Here is the detection limit of standard morphologic remission, which is a count of less than 5% blast. And this is really close to the top of this graph. And we are missing all of the leukemic cells below. Here is the limit of detection for cytogenetics and FISH. And we are still missing a lot of the leukemic cells below. And you can see that it is not that far below where standard complete remission criteria is for the morphologic evaluation. This is the limit of detection for PCR and NGS. These are the most sensitive, but as I said before, NGS is expensive, not standardized, not widely available, takes 2 to 3 weeks, and can detect CHIP mutations. PCR is, unfortunately, only applicable to about 40% of patients. This is an illustration that shows the proportions of MRD targets detectable by PCR in patients with AML by age group. If you look at the gray portions of these pie charts and make an estimate by eye, roughly 60% of patients overall do not have any recurring leukemia-specific markers. If you look at the blue areas of the pie chart, the red areas and the purple areas, you can kind of guess that the NPM1 mutations are the most common, followed by PML-RARA, RUNX1, and MLL fusions. So where does that leave us? Multiparameter flow cytometry. which has a relatively good sensitivity, is applicable to almost all of the patients, 90 to 95%. It has a relatively fast turnaround time. It is relatively inexpensive. However, as I said before, it is difficult to standardize and it does require expert interpretation. So next we will discuss the role of flow cytometry in AML-MRD assessment. So as my professor in college taught me, which is very basic, you can't know what abnormal is until you know what normal looks like. So let's talk about the basics. When analyzing flow cytometry data to perform immunophenotyping in leukemia, you are looking for abnormal levels of expression of antigens that are normally expressed on the cells of interest, or you are looking for an arrest or abnormality in the normal pattern of maturation for that cell type, or there is lineage infidelity, which is expression of a marker that is not normally expressed on that cell lineage. For example, CD7, which is a T-cell antigen, is often aberrantly expressed in acute myeloid leukemia. Another point to remember is that normal cell populations demonstrate consistent patterns of antigen expression and patterns of maturation. Additionally, neoplastic cells invariably will have some deviation from normal patterns of antigen expression or maturation. And to determine how abnormal antigen expression is on a given cell or cell population, you should compare it to normal. In 2017, the European LeukemiaNet made recommendations in an attempt to standardize measurable residual disease testing by multiparameter flow cytometry. I'm not going to read this entire table, but of note is the fact that they recommend combining the leukemia-associated immunophenotype and the difference from normal approaches to immunophenotyping, which I will get into in a minute, and they recommended a panel of markers to evaluate MRD. This is a standard panel on the top row that they recommended, and they also recommended an add-on panel in case a monocytic immunophenotype is suspected. These are the myeloid tubes that have been designed by Euroflow, which is the European Hematology Association's attempt to standardize the practice of multiparameter flow cytometry. So although they don't have a specific AML-MRD panel, these panels would include markers that would typically be used for MRD assessment. To briefly explain the leukemia-associated immunophenotype and the difference from normal methods of analysis. The leukemia-associated immunophenotype is determined at diagnosis. Then at the follow-up, you track it through subsequent samples. The disadvantage to this method is that it does not allow for easy interpretation of immunophenotypic shifts, which commonly occur after treatment due to clonal selection or evolution. The difference from normal method does not focus on a specific immunophenotype. It can be applied if the diagnostic immunophenotype is not available. It identifies aberrant antigen expression or maturational patterns at follow-up relative to normal expression. These are examples of detecting MRD with the leukemia-associated immunophenotype method and the difference from normal method. On the left is one patient with two specimens. One was pre-transplant and one was at relapse. On the y-axis is CD33 and on the x-axis is CD56. These have already been backdated on side scatter, forward scatter, CD45, CD34, and CD117. So this is a CD34 myeloblast population shown in both of these dot plots. And on the left, in the pre-transplant specimen, you can see that there is an aberrant leukemia-associated immunophenotype population showing an aberrant CD34 positive, CD33 positive, CD56 positive leukemic population. And on the right, in the relapse specimen, you can see that the patient relapsed and shows a leukemic population with the same aberrant immunophenotype in the same location on the dot plot. Now on the right is the difference from normal approach. There are two patients, AML1 and AML2, with multiple dot plots representing multiple specimens throughout their disease course. In AML1, the first one is a dot plot for the specimen that was at presentation, and that was a hemodiluted specimen with a lot of peripheral blood in it, so it did not show any relevant cells. I would like to note that the green overlay in all of these dot plots is a control specimen of myeloid precursors of myeloblasts, and the red actually represents myeloblasts in the patient's specimen, normal myeloblasts in the patient's specimen. So in the second one, where it says post-course 1, there is a very small population of events that's highlighted in blue that has shifted from to the left and has dim HLA-DR expression, which is on the x-axis, and it's shifted from where the normal populations are, both in the control and the patient, which are the green and the red. They've kindly put a box around these events. The percentage is 0.03, so they had said it was questionable or indeterminate for MRD. And on the right, an AML1 patient, post-course 2, there is an obvious leukemic population that had dim HLA-DR in that location. It shows that it has shifted from the immunophenotype of the normal populations, and it is obviously a relapse. Going to AML2 patient, this is pre-transplant, so the presentation specimen pre-transplant does not have any leukemic cells. Post-course 1 does not have any leukemic cells. Post-course 2 does have a CD13 negative population of leukemic cells that indicates MRD, and then a post-course or a relapse specimen on the right does show a very large population of CD13 negative leukemic cells, as well as a large population represented in red, which is a CD13 positive or dim that population that merges with the CD13 negative myeloblast population, and that indicates that that patient had relapsed. And that is a representation of the concept of the difference from normal approach. So next, I would like to talk about challenges and future perspectives. There are many reasons why acute myeloid leukemia, measurable residual disease, is so difficult to measure. Acute myeloid leukemia is a clinically, morphologically, and genetically heterogeneous disease with a variable response to therapy. MRD tests measure leukemia cells and not leukemia stem cells. AML leukemia cells have inherent genetic complexity and can undergo clonal evolution and immunophenotypic shifts. There can be loss of antigen expression in response to treatment. Clonal markers can be identified in degenerating or dying leukemic cells, and leukemia transcripts can be detected in non-leukemic cells. These are only some of the reasons, and this is not an exhaustive list of the multitude of ways that measuring AML MRD is so challenging. You can have false positives. Some MRD positive patients in their first morphologic remission may not relapse. This can happen irrespective of the detection method and can be seen either by flow cytometry or PCR. Sometimes the cells may lack the biological ability to cause cancer recurrence. Sometimes the cells may have the ability to cause relapse, but it doesn't occur for unpredictable reasons, such as the cells may never divide. You can have false negatives. Up to 30% of patients in their first morphological remission who are MRD negative will relapse. Sometimes the ability to detect low levels of residual cancer cells is limited by the size of the sample tested. Sometimes leukemia cells are heterogeneously distributed in the marrow. Sometimes large bone marrow aspirates are hemodilute. They can contain more blood cells, but not more bone marrow cells. So if complete morphologic remission is defined by having 5% blasts, less than 5% blasts in the bone marrow as evaluated by a bone marrow aspirate or core biopsy, then what happens if the site from which you obtained the specimen has no blasts, but there are a few leukemic blasts elsewhere in the marrow, i.e. they are heterogeneously distributed? This is what I have tried to represent here with the photos that I showed earlier in the presentation. And on the right, that photo was representing, or did represent, a patient who was in AML remission, and that photo does not have any myeloblasts in it. However, what if somewhere else in the marrow there were a few myeloblasts? What if there were a few locations where there were a couple of myeloblasts? That could represent MRD because it is heterogeneously distributed. This is why synchronous biopsies at several sites may be discordant. There are many technical considerations that affect MRD assessment. The number of events you acquire. If you want a threshold of 0.01% with a CV of 10%, you would have to acquire 1 million events, and they need to be relevant events. What is your denominator? Total nucleated cells, CD45 cells, mononuclear cells? Sample age, collection, and storage are important so that the leukemic cells are preserved. And hemodilution is one of the most common limitations and falsely decreases the bone marrow cells due to peripheral contamination. Less is more. Smaller amounts in the first pull are best. Again, there is a need for standardization of the panel design. Gating and data analysis and other aspects of multi-parameter flow cytometry requires highly experienced interpretation. Two of the more common mistakes is not recognizing an immunophenotypic shift or identifying normal mature myeloblasts as residual leukemic myeloblasts in a recovering marrow. For future perspectives, assessment of MRD and AML is undeniably of prognostic value, but there is no perfect test to assess AML MRD, and it will require a combination of tests. The ideal time points to assess MRD is still to be determined. Is it day 14 during induction when the marrow is hypoplastic and the background populations are reduced, but apoptotic leukemic cells may still be present? Is it at the end of induction when there is active marrow regeneration and increased precursors? Is it at the end of consolidation when normal marrow populations have returned? Should MRD assessment be implemented? I think that this is a definite yes. There is clear evidence that it is prognostically significant. The real question is, can MRD assessment be implemented? I think that it can be, but we still need standardization of panels, specific processing, testing methodologies, thresholds, time points, and a whole lot of other things. But I think that we are approaching a better understanding of measuring residual disease in AML and making significant efforts to standardize MRD testing. Thank you for listening, and let us know if you have any questions. Thank you.
Thank you, Michelle, for that presentation. So we are now in the Q&A portion of the program. But before we get to the questions, I do want to let you know that you will be seeing 2 poll questions on your screen, and we would greatly appreciate your responses. If you are unable to view the polls, please refresh your browser and they should come up at that time. So joining us to answer your questions are a few additional experts. First, we have Abby Kelleher, who is the science liaison, clinical science liaison here at BD, and Darcy Gorgon-Chavez, who is the scientific knowledge transfer leader at BD. Both have been working in clinical flow cytometry for over 20 years each. So welcome to you both.
Hello.
Hello. So we'll try to get to as many of your questions as we can, but our experts will email a response to any questions we are unable to answer during this session. Okay. And so to get to our first question, this one I will be directing to Michelle, our speaker. And so Michelle, first question for you is, do you have any suggestions for determining the sensitivity of a multiparameter flow cytometry assay for MRD?
Yes. So the sensitivity for detecting multiparameter flow cytometry really depends on the number of events you acquire, as well as what you use for the denominator. Are you going to use, total nucleated cells? A lot of laboratories have this, vary on this. Is it going to be total nucleated cells, CD45 positive cells, or mononuclear cells? And so what is recommended by the consensus is that you collect a total of a minimum of 500,000 events. Ideally, it would be 1 million events in order to obtain that sensitivity of 10 to the 4th. And you have expert interpretation in order to achieve that maximum sensitivity, because it does depend on the level of skill of the hematopathologist who is interpreting the analysis.
Great. Thank you, Michelle. And so our next question I'm going to direct to Abby. And this is asking, how do you address the validity of samples from the same individual over time? And they're saying we do survival studies in mice and use patient samples to hopefully monitor disease progression over time in cancer.
Thank you, Annalise. I think what's really important when you're monitoring samples over time is to have a very robust QC program set up. So using whatever your instrument QC package is a very important piece to make sure that your instrument is performing the same day to day and over time. But it's also important to employ good biologic controls for each of your experiments with those patients. So, in some cases, you might want to continue to run normals if you're looking at something like difference from normals. You might want to, look to see where those normals, are appearing on the dot plot to see if they're still in the same relative location. So those are, some of the more important things to consider and put into place to make sure that when you are, looking at samples over time, that you have the controls to ensure that the data that you get is reproducible and comparable.
Okay, that's great. Thank you, Abby. And I hope that was very, very clear for viewer. And so the next question is around the Euroflow panel, and I'm going to direct that one to Michelle. And the question is, in the Euroflow panel, there are multiple tubes. Is any kind of software used to overlay or identify abnormal cells? And what is the basic procedure performed once the 5 tubes are run?
I'm sorry, what was that last part? What is the basic procedure?
Yes, once the 5 tubes are run.
Okay. So this is really basically an interpretation question, and it kind of plays back into the LAIP and the difference from normal methods of interpretation. And really, once you start using 8 or more colors, you get into the realm of being able to combine those 2 methods of interpretation or analysis. And so the Euroflow panels, I'm not sure, I guess when you're talking about an overlay, maybe you're talking or referring to, how you would set up your analysis. Basically, different laboratories and operators have different preferences on whatever types of software they prefer to use for their analysis. And, you could use basically, whatever your preference is, and set up your analysis in a way that makes you feel comfortable in order to see and identify the maturational patterns and the antigen expression in a way that you are able to identify the normal maturational patterns and antigen expression and be able to see any shift from that. And basically, that's really the foundation of being able to identify these leukemic populations, is to be able to, number one, firstly, identify the normal maturational patterns and the normal antigen expression, and to know that normal, and then to identify any populations that are different from that normal. And so you don't need any special, any particular software program or any particular overlays that, Euroflow does actually have some recommendations on that in their effort to standardize, their flow cytometry analysis. And I can't really recommend one over the other, but I think that you should use, any laboratory can use what they feel comfortable with, because it really comes down to being able to differentiate normal or identify normal and then differentiate what is not normal.
Okay, thank you, Michelle. And so the next question I'm going to direct to Abby, and this is, do you have any suggestions on how to concentrate cells to achieve acquisition events of 1 million or more?
Oh, thank you for that question. That's a great question that we get a lot at BD because it is challenging, especially for someone that has a relatively normal white count, or even if they have a high white count. Most of our protocols for staining indicate that we stain something like, maybe 100,000 cells per tube. Those are the staining procedures that we've worked out previously. However, with MRD, of course, we do need to acquire many, many events because we're looking for a needle in a haystack, and so you have to go through a lot of hay to find that needle. And so there are various approaches to that. I mean, one is that you could develop a staining protocol for more cells than that 100,000 that you may have developed. Another approach would be to stain multiple tubes of the same tube, and after the staining is complete, the lysing, the washing, and whatnot, you could combine those tubes together. And the reason for that is that your antibody and cell numbers will remain consistent, so you don't have to worry about the antibody antigen binding kinetics piece there. So I think, you know, any of those approaches might help you acquire that million cells that might be necessary to find that MRD.
Okay, great. And so this next question I'm going to ask Michelle to answer, and it is, do you recommend running the baseline MRD LAIP tube in the case of AML? And can we use NMP1 for MRD now, knowing that it can be positive post-therapy, also in recent papers?
So if you have the opportunity to run the MRD LAIP tube, you know, if you have the opportunity to know what that diagnostic LAIP is, you know, at diagnosis, then yes, you should run it. And because that does help in part when you're doing your follow-up, with the caveat that you have to also recognize that you can have an immunophenotypic shift at follow-up. So, you know, you can have that LAIP population at follow-up, but you can also have an immunophenotypic shift. So it is valuable to know as long as you keep in mind that it could be different at follow-up. So also following with the NPM1 at follow-up, even if it can be positive post-therapy. So if it is positive, you know, since it can be positive post-therapy, even if you don't have MRD, then I would not necessarily use that as a guideline for whether or not I determined that that person was MRD positive. However, these are recent papers, and I think that we need to make sure that the evidence behind using, you know, NPM1, saying that NPM1 is no longer indicative of being MRD positive after post-therapy has been proven sufficiently in the literature in order to make that conclusion.
Okay, thank you for that, Michelle. And for Abby, I'm gonna ask, is there any preference for the stain lyse wash or lyse stain wash for processing?
Not at this time. There is no set, you know, because there is no standardized protocol or method for MRD, for multiparameter flow cytometry. There's also no protocol that has been identified that is more advantageous over another one. You should, if you're thinking of undertaking testing like this, you should try both and determine, you know, the protocol that you feel gives you the most reproducible results.
Okay, good. And this other question, I'm gonna ask Darcy to answer, and it is, what is your suggestion regarding storage of whole blood samples stained with tandem fluorochromes?
Thanks, Annalise. So we all know that when we're handling samples with tandem dyes, are sensitive to light, elevated room temperature, and exposure to formaldehyde. And so our recommended suggestion is to limit all of these. And so keeping your samples in the dark as much as possible, as well as in the refrigerator. Also being mindful how you handle your actual reagents themselves, because keeping your reagents out on the bench top and in the light while preparing your samples will also impact your tandems.
Great. Thank you, Darcy. And so this next question I think is a very good one and a very common one. And I'm going to ask Abby to answer this one. And it's, should you run your compensation controls every time you run your samples?
Thank you, Annalise. You are right. That is a very popular question that we get from a lot of folks. And it's popular, I think, because we get mixed messages about it. And, you know, in a perfect world, I would say that, yes, of course, we should run compensation controls with every single experiment that we perform. That will give you the most accurate spillover values to determine the most accurate compensation matrix, you know, in order to view your data. However, that's not always practical. And while BD, of course, does not recommend any particular frequency to do it, some laboratories have done some testing on their own to determine with their panels, their reagents that they're using, the storage conditions that they're, you know, storing those tandems that we just talked about, are all really important considerations when asking the question about compensation and how often do you run it. And so, you know, like many of our answers, it really should be determined in your laboratory, given the testing conditions that you set up for your assay.
Okay, great. Thank you. Thank you, Abby. And so there's another question here that I'm going to direct to Michelle. And it's about automatic analysis. And the question, Michelle, is what about the the question is, I think they're asking, what about doing automatic analysis in order to avoid operator mistakes?
Okay, so I have seen that there has been some emerging literature that has been published regarding automated analysis or even AI regarding, you know, using artificial intelligence or automated analysis to make the analysis easier, decrease operator mistakes, decrease how labor-intensive flow cytometry interpretation or analysis is, not interpretation, which is what that pathologist does. But I think that is in its infancy right now. I think that it's a great idea in theory. I have some experience with you know, developing algorithms for automated analysis, and it is actually can be very challenging because it's dependent upon how precise or how accurate your ground truth is. Where when you're developing your automatic analysis, you have to feed a data set, many data sets into it, so that your algorithm knows exactly how to analyze it. And that takes oftentimes thousands of data inputs. And the person who inputs this data needs to be somebody who has a lot of experience, so that you know that the accuracy of that data that's going into your algorithm is such that is at a high enough level such that the algorithm that comes out of it makes your automatic analysis be accurate enough so that you're confident that you don't have any, you know, any issues with accuracy at the end of that. And then you can be confident that it is truly avoiding operator mistakes at the end. So I think that that's a great, would be a great tool. It's a really great idea, but I think that that's in its infancy right now.
Thank you, Michelle, for that. And then we have a follow-up question that I'm going to direct to Darcy around tandems, and it's, have you seen tandem breakdown of APCH7 within the expiry of the reagent? And do you see an interaction between APC and APCH7 where it might have a brighter APC median floor value?
Yeah, thanks. This is a great question. And so when speaking about tandems a minute ago, I mentioned the handling of your reagent itself. And so we often, when we're preparing cells, take all of our reagents out of the refrigerator at the same time. And so our reagents end up sitting out on the bench top and coming up to room temperature. And that will impact all tandem dyes. So when you're seeing tandem dyes break down within the expiry date, what you want to focus on is the actual handling of your reagents. And do we see an interaction between APC and APCH7 where that your APCH7 actually looks brighter in your APC channel? Yep, and we can, because as a tandem does degrade over time, we lose that secondary shift in fluorescence, and we get more fluorescence from the primary fluorochrome. And that's either an indication that your reagent hasn't been handled properly, taking into account that you have actually optimized your PMT voltages on your cytometer itself, and that your voltages aren't setting correctly where you are artificially seeing this effect.
Okay, thank you so much for that, Darcy. And then I have one last question, and then we'll wrap up our Q&A. This is a question around dilution, so I'm going to direct this to Michelle, and it's, how do you judge the dilution of the sample by looking at the plot?
Okay, so I think that this is probably referring to hemodilution. So this is really actually pretty straightforward. To determine hemodilution of a bone marrow specimen when you're looking at your plots, basically you're really going to see an increase in your mature neutrophils, and you're going to see a decrease in immature myeloid cells and blast. You're probably not going to see any blasts, or like you probably won't see any blasts, and you'll see a decrease in your myeloid precursors. Sometimes it's very striking. Sometimes it can be more mild, but you will definitely have a shift towards mature segmented neutrophils with CD15.
Okay. Well, thank you, Michelle, for that answer, for the presentation. Thank you to Abby and Darcy, our experts, for joining us for this panel discussion. And as we wrap up, note that CE credits will be given to attendees, so look for an email with more details on that. And also, a recording of this presentation will be available on the webinars playlist of the BD Biosciences YouTube channel, and then also on the webinars page of bdbiosciences.com. And so with that, thank you for joining us. We hope that you found this insightful, and we look forward to seeing you on another webinar. Have a great day.